So I'll just quickly wrap up teleophthalmology and AI in retinopathy of prematurity. No financial interests again. Whenever we talk of ROP, two major studies, whenever we're talking of telemedicine in ROP, Sundrop, that is the Stanford University, they linked 6 centers together, 1200 some odd photographs, analyzed them. And then we had KDrop 2011, 2014, 2016. There were problems with both the studies, benefits of both the studies, carried them forward. And then the message that was carried by us and the message that actually finally has emerged are two slightly different things. Now, Sundrop 2005 to 2011, 1216 eyes, 26,000 images, positive, negative predictive values as shown here, high 90s. Karnataka, the KDrop 2011, they gave us 7,000 odd infants, did not give us screening criteria, comparison criteria. In 2014, same thing, RedCam shuttle, store and forward mode. RedCam shuttle, click the images, forward them. They compared with non-physician grading of images versus expert live examinations. Expert live examinations with store and forward imaging. Now this is where what they had done was, they said we will grade our optometrists into 3 levels and they would be given, depending on their level of proficiency, they would be permitted whether they can say, you know, it requires a referral or it requires a discharge, right? And interestingly, at that moment in time, we criticized that model, but subsequently the same model was used by Europe, right? So apart from India, we have experience from Chile, Peru, and Germany. In Chile, 11 NICUs were there. Again, a RedCam shuttle was used, like it was used in Karnataka KDrop. The evaluation was by 2 ROP experts, 5,000 imaging sessions performed. 98% of the images could be used for evaluation. In Peru, it was about 97%, which was suitable. And in France, it was a smaller study, a RedCam 120, but it gave us no positive predictive values. The German study was very interesting because it picked up all the 40 cases which required treatment out of 1200. But look at the positive predictive value. It was in early 80s. And then we went back and we tried to look at what the data said. It says only 21% of the NICUs are using retinal imaging devices today, and only 30% of neonatologists agree that telemedicine is safe for ROP screening. In practice, we all know the hybrid model involved in North Carolina, and that was the Sundrop model. And we have the EROP study where wide field retinal imaging was performed and interpreted by non-physicians with examinations performed by physicians, 1200 infants who received a median of 3 imaging sessions with conventional live surgeries at 12 sites in the United States, 1 in Canada, and this was between 2011 and 15, immediately after that one. In practice, what is used is contact wide field photography, which is usual, the RedCam and all. And given these were the sensitivities and specificities given at the bottom there, right? Now, the IROP, which was the Imaging and Informatics in ROP Consortium, reported a higher accuracy for Zone 3, Stage 3 disease if you performed live examination. So if it is the borderline which has to be decided, the live examination still remains the gold standard. And that has actually been translated into the guidelines also. Now, then of course we had the same thing, EROP also used it, the non-physician grader, we talked of those, training them, using lectures, giving them pre-certification, then giving them 100 images. If they crossed 85% accuracy, they were given that certificate. Right, now we come to that, where's that? Have a look at the second point. The weighted kappa is 0.72 for intergrader, 0.72, which is good, right? 0.57 to 0.94 for intragrader. Now you understand what I was saying. And now this doesn't stop here. So the trained physician will still, as of today, remains the mainstay. Now let us take it to our trainings. So it has become a tool for us for training also. We do not, and this is not me, this is a US study which is saying it. There is no standardized method of assessing competency among ophthalmology resident and pediatric ophthalmology fellowship program. So they came up with Global Education Network ROP group, and these are the sites, and improvement has been reported. Right? Now, what are the AI techniques used? Now, very interesting thing that they did was, instead of training it like this, before the convolutional networks came, we had something called ROP tool system. And what ROP tool system did was, it took out the size of the vessels, and based on the size of the vessels, it gave you a score. And that score conformed well with the grading. Now this was very interesting because we had, you know, 5 stages, 5 grades, then plus disease, no plus disease. Later we put all those things together and got much better sensitivity and specificity values. But the first one was this one, and this was not a convolutional neural network. And the CNNs were based on about 5,000 images here. And then we have 2 or 3 more which are based on, you remember AlexNet, GoogleNet, and VGG16. And we have for identification purposes, it's IDNet, and for grading, it's GDNet. And look at the sensitivity and specificity in the late 80s. Negative predictive value, almost 90%. But let us go back to the guidelines. And what do the guidelines say? The guidelines support the use of remote digital fundus imaging to identify individuals with referral warranted ROP. Yes, you can use it to identify referral warranted IOP, but have at least one binocular indirect ophthalmology examination before the initiation of treatment or termination of ROP management. That means, in the end, the guidelines have stopped just short of accepting. They still place, you know, the human being as a trained ophthalmologist should discharge the patient from treatment. So that is the take-home message for it. And now let us talk of all of us know what those wide field systems are. RedCam, all of us are available with, are aware of RedCam, Shuttle, RedCam 2, whatever. Then Visionax, Finex. This all of us know. A lot of us have been involved in development and progression of this particular thing. And this is very much an Indian phenomena. And now we also have a non-contact one which is performing fairly well in type 1. That is aggressive posterior ROP. And but still the take-home message remains that the human being, the trained human being, has to take a final call.